Good morning, everyone. Bonjour, bienvenue, welcome.
Is the microphone working?
I think the microphone is working. Yes. Our numbers have diminished, Kingsley. Should we be worried, or are we just push on?
We're keeping track of who is in, who is out. So next time, those who are not here will not be invited. That's it.
Wow. Okay. Well, welcome to those of us that are here and won't incur Kingsley's wrath. Okay. Very pleased to open and chair this session. My name's Tim Stanier. I'm a microbiologist from the Doherty Institute at the University of Melbourne, and it really is a privilege to chair this session. I will not waste any more time and move straight to our first presenter, who's Dr. Isra Cruz, who has spent a lot of his professional career in this space of diagnostics for neglected tropical diseases. Isra, over to you. Thank you.
Thanks very much, Tim, and also thanks very much to WHO NTD team for inviting me to this meeting. I have the assignment to go a little bit through the situation regarding diagnostics for skin NTDs. I believe we all will agree that diagnostics are essential to address most of the present public health needs in a sustainable manner. We can apply diagnostics at a patient level to apply the correct treatment and make the patients able to access health, but also the community to control epidemics, to address antimicrobial resistance, and also diagnostics are useful at the program level, of course, for data. They provide data for intervention, guide elimination, cost reduction, etc. For neglected tropical diseases, we will also agree that diagnostics are also a key component. They're applied in detection, management of cases, and they also support surveillance activities regarding strategic planning. They are also useful in assessing distribution of disease, mapping of disease, monitoring elimination, interruption of transmission, as well as certificate elimination. Okay. And fortunately, for people like us working on diagnostics, we are living a momentum regarding these tools. And very relatively recently, you will know that WHO launched the essential in vitro diagnostic list, acknowledging that without adequate diagnostics, the patient's journey is uncertain. The situation is a little bit sad, if you want, from starting. Although in vitro diagnostics, they are important in most of the decisions when taken at the healthcare level, a little budget is invested in this tool. That means that in many low and middle income countries, only diagnostic capacity, diagnostic tests are available in around 1% of the primary healthcare clinics. And this means that incorrect diagnosis is given to more than 2/3 of the patients. The health workers, they feel powerless because they cannot provide an answer to the patients, and patients cannot receive appropriate treatment. Continuing with this momentum, during the development of the NTD roadmap 2021-2030, diagnostics were highlighted also as a key component if we wanted to reach the targets for the different neglected tropical diseases. Diagnostics for NTDs, and as they are acknowledged in the roadmap, they will help accelerate elimination of diseases, providing data to inform strategies. They, of course, help reducing morbidity because they are useful for case detection and treatment, or not to treat people when there may be adverse effects, like in some MDA campaigns. They help reducing and optimizing cost of the programs, the companies donating drugs, and also the donors supporting programs. They help in effective targeted treatment, and also they reduce MDA years if they are used properly. and they support also monitoring, evaluation, and surveillance activities, as they can inform on the intensity, frequency, and duration of intervention and monitoring the efficacy and of these interventions and also the disease trends. Okay. During the development of the NTD roadmap, there was an analysis of the gaps in terms of diagnostics for the different neglected tropical diseases, as well as an assessment of which should be their priorities. If you look into the skin neglected tropical diseases, you will see that most of them are currently diagnosed based on clinical assessment. For many of them, we could use also microscopy to support clinical diagnosis, but microscopy, as we know, is not always available. For a few of them, PCR is recommended, and when it is done, it's usually at the reference center level, not where the patient is managed. And in very few, just one of them, you can also use RDTs to support the clinical diagnosis. So the priorities identified for the different neglected tropical diseases in terms of diagnostics were, on one hand, to maintain and strengthen the clinical diagnosis, especially when diseases are approaching elimination targets, for example, for leprosy. It's important to keep up this clinical suspicion. To develop rapid diagnostic tests that could be used at the public health center level and at community level to diagnose suspected cases and at-risk population, like, for example, for Buruli ulcer, cutaneous leishmaniasis, or leprosy. Tools to assess pathogen viability in diseases or for diseases where treatment is long or is difficult, like mycetoma or Buruli ulcer, differential diagnosis and assessment of drug resistance and drug sensitivity, like, for example, distinguishing between species of Leishmania or Treponema pallidum and Haemophilus ducreyi infection, which drug you want to provide to people infected or affected by mycetoma, etc. And of course, improving sample collection and sample processing approaches to be used with this test. And also population-level tools that could be integrated in programs working at the population level, like using strategies like preventive chemotherapy, etc. But we talk about skin NTDs now. We are also talking about integration, integrated management, and also integrated diagnostics. I take advantage. So for integration, we will need to pay attention to different aspects. One of these will be the training or development of training packages. Not only on basic dermatology beyond vertical programs, because now health workers should be able to address different diseases, and they will need to get information on the different clinical manifestations of other diseases in which they will be involved, but also in the use of new tests and what will be the role of the different apps or artificial intelligence-enabled tools. Technical support will be needed for the introduction of new tests. Also, we will need to address an always present problem related to access, logistics, and supply chain, but not only when the test is developed, but also when companies, for example, they step out in production of a diagnostic test. We will need to bear in mind that this is something that can happen, and unfortunately, we have witnessed this with visceral leishmaniasis. Also, we need to work hard on advocacy and funding, country ownership, domestic financing of the products, and address implementation barriers to adoption and assess the impact of a new test in a weak health system, because we are talking about innovation, we are talking about developing new tools, but the introduction of them in a weak health system can have a negative impact. But talking about integration, we don't want to develop only point-of-care tests or rapid diagnostic tests. We may need to think also about developing multiplex platforms that allow integrated diagnostics. For this, we will need to do research on biomarker discovery, biomarkers that can be multiplexed. Also, a common sample processing approach if we're talking about diagnosing different diseases with the same platform. And when we reach this, we will be able to develop this multiplex platform that will enable differential diagnosis panels, will help in mapping co-endemicity of diseases. Or if we want to go to the low-hanging fruit, we can work and develop strategies to work on shared instruments and platforms like miniaturized PCR or other simple and robust nucleic acid amplification tests like LAMP or RPA, for which there have been many developments for many of the skin-neglected tropical diseases. Of course, these multiplex platforms, we would like them to also fulfill the assure and reassure criteria we ask for the point-of-care test. So they will need to be affordable, sensitive and specific, use-friendly, rapid and robust, equipment-free or using simple equipment, environmentally friendly, and of course they're available to the end users, as well as the need for real-time connectivity to help or to inform quickly the programs and address in an easy manner the specimen collection and processing approach. And if we are getting into developing diagnostics, we have to be careful, and we will need to address important aspects related not only to the scientific or technical, but also to the market and policy, because failure is there. And it is said that diagnostic development process goes through 3 valleys of deaths. The first one is the one related the one in the process from the concept of the idea to the product development. If you don't have the good scientific and technical support, and you have not think very well on the use case and the market, about 40% of the tests will fail. In the phase between product development and commercialization, if you don't bear in mind properly regulatory and policy aspects, and also operational aspects like a scale-up, what will be the product support, etc., another percentage of the ideas or tests will fail. And in the last valley, from commercialization to adoption, if we don't think properly and in advance about the resource needed and the sustainability, another important amount of tests will fail. So ideally, we should be moving from a more research-driven approach to a system-driven approach and try to work together. There have been many diagnostic tests developed by research organizations that have not made it to the system, that are there, they have been published, there have been some evaluation, but in the end, they have been never implemented. So for this, we need to bear in mind that integration of these tests or these prototypes and finally products into practice depends on a very complex network of actors in the health system that goes from individuals to governance level. Okay. Another important challenge that we will need to be addressing is the financial one. I mean, we are always complaining about this in the world of neglected tropical diseases, and I would say that especially in the field of diagnostics. If you look into the GFinder report 2022 for showing data up to 2021, we have seen that after a peak in investment on R&D funding for neglected diseases in 2018, the funding is decreasing. If we talk about neglected diseases by GFinder, they also include HIV, tuberculosis, malaria, as well as diarrheal diseases and respiratory infections, among others. So it's not only WHO neglected tropical diseases. And we can see that most of the funds in 2021 were allocated to R&D activities for HIV, tuberculosis, and malaria, and very little for skin NTDs like, for example, buruli ulcer, mycetoma, scabies, or leprosy. So what we are expecting to get is very little. And actually what was addressed for diagnostics development was only about 4%. So we're talking about developing diagnostics for neglected tropical diseases. We will need to think very carefully on the financial aspects. So how are we addressing the challenges? How the community is addressing the challenges. On one hand, I think this is a very important aspect, is the creation in parallel of the development of the NTD roadmap, the creation of the WHO Diagnostic Technical Advisory Group for neglected tropical diseases. This is a group of people that is supporting WHO NTD program in addressing priority areas for neglected tropical diseases, diagnostics, in identifying gaps in access to the currently available tools, and also advising on the innovation and developments required to ensure that the diagnostic process is able to properly inform decisions about the work to combat NTDs by WHO and partners. This DTAG has different subgroups for diseases of diseases groups, but has one dedicated subgroup on skin and neglected tropical diseases. And one aspect this group has been working lately is in the development of the target product profiles for priority diagnostic tests, meaning documents that will guide the development of priority diagnostic tests for skin neglected tropical diseases. But this group on skin NTDs also interacts with other cross-cutting DTAG subgroups or activities like the subgroup on laboratory capacity strengthening and biobanking related to improve or connect networks of laboratories, develop standardized protocols. Biobanking is another subgroup which is more dedicated to make accessible the specimens needed for evaluations. The subgroup on clinical diagnosis, imaging and microscopy, which also pays attention to quality control activities, standardization of processes. The surveillance group will look into a platform that could be used for multiplex analysis and helping in surveillance activities, but also groups working on manufacturing and regulatory pathways, which are very important for the diagnostic test, which sometimes is not that easy because of the interest of the company. And of course, the not less important groups working on global investment and resource mobilization, trying to understand the market needs, how funds can be obtained to develop these tools, and how much money is actually needed for developing these different tools. And out of the DTAG, this group also collaborates with the WHO network for artificial intelligence used in skin NTDs, so to help in skin NTDs activities. So we show a little bit on the target product profiles developed by the skin NTDs subgroups. As I was saying, these are guidance documents developed in conjunction with key stakeholders. The participation is by disease experts, but also people working in the industry and developing the tests, ideally people from regulatory agencies, different expertises like health economics, etc. And the idea is to develop documents that will show what is the scope of use of the desired test, what should be the performance characteristics, the operational characteristics, depending on the setting you are planning to use the test, and other things like costing of the different tests. So ideally, these documents would facilitate the development of health products that will address the main and most urgent public health needs. At all stages of the process, it will acknowledge access, equity, and affordability, and they will serve as strategic documents that will show or that will be used to align industry, funding, agencies, people doing research in development of tools with the WHO preferences. For the different skin neglected tropical diseases, a number of target product profiles have been developed by the skin NTDs subgroup of the DTAG. For Buruli ulcer, one of the priorities identified after reviewing the priorities set in the NTD roadmap is a rapid test for diagnosis of Buruli ulcer at primary healthcare level, which is similar to the need for cutaneous or for dermal leishmaniasis and for mycetoma. For leprosy, two target product profiles were developed. on one hand, a diagnostic test to detect Mycobacterium leprae and Mycobacterium lepromatosis infection, and on the other hand, a diagnostic test to confirm the diagnosis of leprosy in individuals with clinical signs and symptoms. So here we are talking about different tests that can be used at population level to trace contacts, people at risk, etc., in order to diagnose disease itself. For scabies, 2 TPPs were also developed. One is a diagnostic tool for starting mass drug administration, and the other a diagnostic tool for stopping MDA. And for those, 2 different tests, one for identifying a single case of yaws, so diagnosing of the disease, and the other for detecting azithromycin resistance, which is a growing problem for this disease. There are, of course, many other activities also related to laboratory capacity initiatives, and you will see many of them presented by colleagues in this session. I would like to highlight an activity conducted by WHO in 2019 in collaboration with the Public Health Laboratory Ivo de Carneri in Zanzibar, which is this training workshops with laboratory personnel to improve the capacity for diagnosing neglected tropical diseases. Ideally, these type of activities should be repeated, and I know that they are being repeated by different partners also. But also you will see our colleagues talking about other networks like the Buruli Ulcer Laboratory Network in Africa, the Land for Yours project, and a project on multiplexing molecular diagnostics that we will hope you will enjoy. So thanks very much, and especially to my colleagues in the DTAC, from which I'm learning a lot every time we meet and every time we discuss. Thank you.
Thank you very much, Isra. I mean, it's a perfect start to this session to frame our thinking around diagnostics, which is central to our activities. We're going to hear in this session how hard it is to move in this space, to progress. Without diagnostics, we're lost. And I know in our own experience in Australia, the development of the PCR just changed our approach to Buruli ulcer completely. But the work in that space is not done. And you're going to hear this morning on efforts to bring that diagnostic capacity right into the remote regions and areas that really don't have access to high lab capacity. I'd like to now invite Dr. Sarah Iyongo from Cameroon, who has been a leader in the field of laboratory capacity strengthening across West Africa. And Sarah, over to you. Thank you.
Thank you. Thank you, team, for giving me the floor. I would like to start my talk by expressing. By expressing my gratitude to all Buruli Ulcer Laboratory members, as well as founders and experts. So it's a real pleasure for me today to present on their behalf, a great opportunity to us during this first WHO meeting to present what we have realized or learned so far, what we are looking forward to achieve, as also as also us challenges we encountered. So what is the history, a brief history? A brief history of this Buruli Ulcer Laboratory Network. In the past decade, as you well aware, the Institute Tropical of Medicine in Antwerp has been organizing a helpful external quality assurance for molecular diagnosis for Buruli ulcer. The last AQA program was organized in 2018. And during the last meeting in the BU lab meeting in Geneva in 2019, they announced a discontinuation of this program. Since there was still a need to have an external quality assurance program, WHO decided to implicate a volunteer lab in Africa to continue to run this program. The criteria for selection was based on the quality of the performance of the lab during the ITM program. So it is why the mycobacteriology lab of Centre Pasteur du Cameroon was selected to continue to run this program. So it is then that the Buruli Ulcer Laboratory Network was created in October 2019 during the meeting held in Cameroon, starting with 11 laboratories from 9 countries, and today we have 13 laboratories. So what are the main objectives? The network has a principal goal of establishing a new model of external quality assessment program. Our specific objectives are the formalization of a network of laboratories, harmonization and standardization of procedure for BU diagnosis to be used by all these network labs. This is a critical step to implement an efficient external quality assurance program. Another objective was also laboratory assessment and also supervision and training. The idea behind this intervention was to ensure that the results obtained by this lab are for good quality and above all are comparable. We are able to compare all the results we have in Africa. In the long run, we envisage implementation of the same strategy to other skin NTDs and to integrate the diagnosis in the same molecular platform in African countries. So what have we realized during these past 3 years, despite the COVID-19 pandemics? So first thing we can say that we have a functioning network. The network, we have 2 additional laboratories. We start with 11 laboratories. We were able to formalize a membership for all these volunteer labs based on their real-time capacity. We create an advisory board to help us to review activities and also what we have planned, an expert panel to support training and also a laboratory assessment. We held a regular meeting with all the members, 2 in-person meetings in 2019 and 2022 last year, and 2 online meetings in 2020 and 2021 due to COVID-19 restriction. So also an important milestone was the MOU signed between WHO and the coordinating center. The foundation work of the network started in 2019 with the collection of BU PCR testing procedure for all these 11 initial labs. These SOP were compared in all the steps, step by step, from standard DNA extraction protocol, the mix we are using for real-time PCR, including probes, primers, and DNA standard. And we succeeded to obtain the consensus of all members so that we developed and selected 4 SOP, which were validated and now are used by all the labs. Thanks for the organization of Raoul Folero, French Foundation. Corresponding reagents for all these validated procedures were purchased and sent to the lab. American Leprosy Mission also purchased consumables to this lab. In order to evaluate the implementation of this newly validated developed procedure, the first AQA program was launched in 2021 with an overall mean of score around 18%. As you can see in the table, 3 of the 12 participating laboratories had a score below this target. So for this lab, we performed a troubleshooting And this troubleshooting also include newly prepared proficiency sample testing with the test and score 100%. In the second round, in 2022, we see that all participant labs are above this score. Only one lab needs troubleshooting. We plan the third AQA program in June 2023. Human capacity, also human capacity building is also one of our objectives. In collaboration with OSEAC program in the sub-region, we also train at the Coordinating Center personnel from Central African Republic and also Congo in Buruli-Ulcer for Buruli-Ulcer diagnostics. They are going on with these diagnostics. We are following up them to see how they can integrate according to the level of the diagnosis. So the lab visit, the assessment were planned in 2020, but it was delayed due to COVID-19 restriction for travel. But last year, in 2022, a huge milestone was achieved so that all the 13 labs were visited by at least one expert. We use this opportunity to thank all those experts who took off time to conduct the laboratory assessment. The objective was to evaluate the diagnosis capacities of each of the laboratories to perform this molecular diagnosis with high quality, and also to assess the gap in personnel, in capacity, and also in infrastructural capacity of each member in order to create a kind of baseline for capacity building activities. So when we found, I think the main strength was to have a diligent, a motivated staff performing real-time PCR for Buruli-Ulcer using the SOP we have validated. We have infrastructural capacity was good. Only one lab, I think only in one lab there was no the 3-room setup for qPCR, and the average turnaround time was acceptable for all the labs. So the main area of improvement, most of the lab had issue with equipment maintenance, calibration, or certification. So you can find in our website, we have now on the website, you can find on our website our TOR, the harmonized procedure, and also in last October, our first paper on the milestone achieved was published in PLOS Neglected Tropical Diseases. If you can have a look on the laboratory workload, we have talking about activities implemented to ensure quality, so we can have a brief look on laboratory diagnosis. We saw in the aggregated workload a steady increase of activities, but the PCR rate still low. And so that is opportunity also to call for BU program collaboration with those labs where we are working to improve capacity and quality. So the main perspective is since it's order to optimize the use of this limited resource, the main perspective is to expand our network and integrate other skin NTDs like yours, cutaneous leishmaniasis and mycetoma and leprosy in the same molecular platform. So there is a progress of integration of yours activity is currently ongoing. We have a training of a member of BU LabNet at the Mycetoma Reference Center last March. This opened the perspective of SOP harmonization, and we are working with Professor Fahal with this focal point to continue on this aspect. We would like also to enhance opportunity for collaborative and integrated approach so that, but we did not yet succeed to secure some funds And we like this also laboratory, when we improve quality, to be like a platform for others, pharma, so that we can evaluate the quality of new method of diagnosis. We like also to have a digital platform for data sharing so that lab will use to share the data easily. We need also to build a data sharing agreement as well as material sharing agreement for biobanking for future study. Oops. So the main challenges at this point, the main challenges is to sustain reagent and consumable supply. If funding of reagents ends, will this be feasible that national program continue with supply laboratory for reagents? So we are also, we like also, the challenge is also to secure, one of the challenge also is to improve the collaboration between BU LabNet and laboratory to samples transfer. We have to continue advocacy for, to get funding for collaborative studies. Communication to let know what we are doing also has to be improved. And as I say, one of the challenges is also equipment maintenance in all these laboratories. So the main take-home message is that harmonization of procedure, I think, is essential to improve diagnosis quality, and this is applicable for all diseases. And our long-term goal is to expand and include other NTDs in the same molecular platform in those countries. So we are happy to announce the next general meeting in Accra next October. During the meeting in 2022, we invite experts to expose on the diagnosis, and we would like to move on with talking more about harmonization of procedures. So you are welcome. So I would like to conclude by my acknowledgement. We are here today talking about the network, which will have not been possible without all network members' laboratory. Thanks to the Centre Pasteur du Cameroon, we have hosting the coordinating center, capacity building, and unwavering support from WHO. American Leprosy was there at the beginning to have funding the coordination activities and supply for consumable. Raul Folero funding BU reagents, as well as Anesvad came in later, but support capacity building, evaluation visit, and annual meeting, thanks to members of the network and advisory board and expert panel. So thank you for your time.
Thank you, Sarah. That was inspiring. I mean, that you have been able to lead and run this during the pandemic. I mean, it's such important work to have assurance that the diagnostics are of a high quality and a high standard, and that really hats off to you and your team. Very well done. We will move now to staying with the theme well, moving to perhaps point of care or mobile diagnostics, and I'll invite Sandeep and Michael to present their work. Thank you.
Good morning. Thank you. I'm Sandeep, Senior Director of Research and Innovation at American Leprosy Missions and Senior Research Associate at the University of Cambridge. I don't have any conflicts of interest to declare. I'll be talking about the point-of-care and field-compatible qPCR-based molecular diagnostics for skin-neglected tropical diseases. These are the partners on the screen. The aim of the study is to evaluate the use of Biomeme Franklin mobile qPCR for accurate detection of Mycobacterium leprae and Mycobacterium ulcerans DNA in clinical samples. We have specific objectives to determine analytical sensitivities and limit of detection of RLEP and insertion sequence element, IS2404, using Biomeme qPCR in comparison to standard qPCR systems currently in use in 3 WHO-approved reference laboratories for BU and 1 research laboratory for leprosy in India. We also aimed at evaluating the mLAPRE and mLSERENS qPCR assays, we call them Biomeme ghost strip assays, for confirmatory diagnosis of leprosy and Buruli ulcer using clinical samples. Biomeme Franklin mobile qPCR has several innovative features. Once sample collection is achieved at the point of care, DNA can be extracted using a cartridge-based system. So this is called as M1 sample prep cartridge. The cartridge is fabricated with extraction liquids in each chamber, if you can have a closer look. And then it also has a syringe with a column that can trap either DNA or RNA. Extraction can be performed at the point of care or in a field setting, and it takes about 2 to 3 minutes. It's not just lysing the bacterial cells, but it also has capabilities to explode the cells so that the DNA can be extracted. One of the most innovative features of this technology is the qPCR reagents can be premixed, standardized, and freeze-dried. So the primers, probes, and the master mixes the concentrations can be standardized on standard positive control DNA on the samples, and then premixed and freeze-dried so that the assays are shelf-stable at room temperature. So these are manufactured by Biomeme. We can do a lab standardization, submit it to the company to manufacture these ghost strip assays. What we have noticed with these assays is that they remain quite stable at different temperatures for up to 18 months. Then the qPCR is a battery-operated device. It's fabricated with a battery, and it runs for up to 6 runs. Each run takes about 50 to 60 minutes from sample to results. It's a 3-plex device with 9 wells, so one can do up to 27 gene targets in 1 sample or 3 genes in 9 samples. System is operated using a mobile phone app, which connects to the PCR using Bluetooth, so there is no need for internet connectivity if it's being used at the point of care or in a field setting. Once internet connectivity is available, the data from the mobile phone is automatically uploaded to a secured cloud portal, which enables remote monitoring and access to results. It also provides access to the real-time running of the experiments. Another feature, before I progress further, is that even the protocols need not be set every time when an experiment is done. Along with the assays, a barcode is provided so that a mobile phone can scan the barcode and capture the protocol to keep the system intact. We have generated evidence using Biomeme for leprosy, Buruli ulcer, and COVID-19. The company has FDA's emergency use authorization for COVID-19. We tested it on the bench in India in late 2018. And then we also tested it at the bedside, and my colleague, Michael Frimpong, who's going to present shortly, has tested it for COVID-19 in mobile labs, as you can see below in the community in Ghana. For assay development and clinical validation, we partner with labs in NTD endemic countries. We test Biomeme qPCR on clinical samples. We standardize and develop qPCR assays, and then we validate these assays against the prioritized use cases in the TPPs. For Buruli ulcer, with our partners in Ghana, that's the Kimasi Center for Collaborative Research and Noguchi Memorial Institute for Medical Research, and also Centre Pasteur in Cameroon, we were able to test, standardize, and also manufacture the assays under the ALM Biomeme co-developer agreement. We have noticed a sensitivity of 90% and a specificity of 99%. My colleague will talk more about it. The assays were manufactured, as you can see, the ghost strips on the side. We are planning to submit them for regulatory approvals based on the existing data. For leprosy, we progressed with our colleagues in India and also at the Colorado State University and managed to standardize the qPCR assay. Assays are being manufactured now, but we need to really validate them with the partnership and support of the the colleagues in the space. In our initial experiments, we have noticed a limit of detection for Mycobacterium leprae DNA, that's the RLEP, and as low as 1.34 genome equivalents. We could get a CQ, which is equivalent to CT, is 34.39 using biomeme, and the standard qPCR has shown about 36.87. We also run a simple correlogram to understand if the CT values of the standard qPCR matches that of the biomeme, and we could see a very good correlation of R square of 0.99. We also tested biomeme setup on the leprosy samples, biobanked DNA samples from leprosy cases, household and familial contacts, and endemic controls, as you can see the numbers there. And we have determined these mean thresholds that are significantly different across the study groups. Using those mean CQ values, we could diagnose possibacillary leprosy up to 95% sensitivity and multibacillary disease up to 99% sensitivity. From here, my colleague Michael will take over.
Thank you, Sandeep. I'll just go through the development phase quickly and show you some results that we have evaluating this assay in 3 BU LabNet laboratories. So following the validation pipeline, what we wanted to do is not to change any of our protocols that we have already established through the BU LabNet, but then take that wet reagent protocol into the dry-based reagent protocol that is compatible with the biomeme PCR assay. So that is what we did by optimizing the cycling conditions using the same protocol, PCR protocol that has been developed for the Borreliosa based on the IS 2404 protocol. So after developing the assay and then converting the standard PCR protocol that we have in the laboratory onto this portable platform, we wanted to evaluate this using biobank samples across 3 different laboratories. And as you can see in the results, these were very comparable across the 3 laboratories with a sensitivity well above 90% and a specificity within 90 to 100%. What was interesting with our results that we saw was that using the biomeme dry reagent protocol, it did not affect the sensitivity of the test, because sometimes in developing assays, when you change the wet assay into a dried assay, it tends to affect the sensitivity. But we did not see that with the biomeme platform. So when we do a comparison of the CT values for the standard, the centralized PCR platform to this portable PCR platform, which is the biomeme PCR platform, it actually shows that the CT values that we were getting for the same samples across these 2 PCR platforms were even lower in the biomeme platform, showing that the sensitivity of the assay has not been affected by converting this wet reagent into a dry reagent format. But that was with samples that had already been extracted, right, and stored. These were DNA extracted and stored. The question we've had going to the field with all these point of need development assays to the field has been the extraction method. So we wanted to test the biomeme sample prep assay, whether it will give us a very good extraction once we take it to the field. So these were samples that were taken across these 3 laboratories with fresh samples, tested, and as you can see, the sensitivity then dropped a little across the 3 sites. Now the sensitivity dropped from around over 95% to around 82%. So it shows us that there is still room for improvement with the extraction assay. But at least for the field, this over 80% sensitivity is good, but there is still room for improvement. So I will leave it to Sandeep to just give us the key observations and then our conclusions.
Thank you, Michael. So the key observations are that the biomeme qPCR was able to detect mLEPR and emulsiran's DNA with equivalent or superior efficacy to standard PCR in clinical samples. Lyophilized biomeme qPCR assays for BU remain shelf-stable. We tested it over a period of 1 year, and we have seen that they're quite stable. And we were able to test the system at the point of care and even in the community. For the future, we would like to develop the biomeme multiplex qPCR assays for skin NTDs. In this panel, we would like to include leprosy, BU, cutaneous leishmaniasis, yaws, and mycetoma. We would really like to explore the multiplex capabilities of this system and expand the development and evaluation process. For this, American Leps Emissions and NSWAD Foundation has stepped forward to support. We will also look towards validating the qPCR assays for leprosy in a multicentric trial. And also, we look forward to submit the BU assays for regulatory approvals. Thank you very much, and this is not possible without the partners shown here. Thank you.
Thank
you. Thank you, Sandeep and Michael. Just a reminder that we will ask questions. We will open for questions at the end of this session after a few more speakers. Terrific demonstration of the challenges of trying to deploy improved molecular diagnostics in the field and the value of biobanking, which is critical for assay validation. So well done. All right, we will now move to our next speaker. Someone who has quite some experience in trying to deploy novel diagnostics in this domain. So Tizom de Souza, if you are ready to present, I will hand over to you.
Thank you very much. So I'm presenting work that has been done together with FIND and some other partners with TPH, DDTD, and Nagasaki University, alongside other partners in disease endemic countries. So I'll skip most of this introduction on Borrelia ulcer. The only thing I will say here is that we know early detection and treatment remains the only option at the moment, but demands the need for confirmation before treatment, given the high misclassification of clinical suspected cases. So at the start of this work, the WHO Diagnostic and Technical Advisory Group identified BU as one of the diseases requiring new diagnostics to facilitate treatment. There are a few effective diagnoses for BU, the reference PCR having the highest sensitivity and specificity, but its availability in treatment centers was a challenge. And so WHO recognized the need for an RDT to enable identification of BU in early cases close to the patients. This would then overcome the challenges with referring patients or samples to reference laboratories, sometimes taking time before the results are received. So in 2018, FIND together with WHO led the development of a TPP for Borrelia ulcer, the aim of which was for Borrelia ulcer. So the aim of this project basically was to develop a rapid diagnostic test for Borrelia and generate the evidence for use in endemic countries, with the expected impact that this will simplify diagnosis to enhance testing at primary care and community levels, reduce turnaround time, and improve treatment and monitoring. So going forward, one of the target molecules identified in that BUTPP was mycolactone, the toxin produced by the bacteria. It was selected at the time as we believe that this would be more readily available in the ulcers, and also due to the reported sampling challenges to detect DNA for molecular assays. However, mycolactone, we know, is amphipathic, has both hydrophilic and lipophilic properties. It is unstable in aqueous solutions and has the ability to self-aggregate. Its storage in organic solvents is ideal for stability and recovery, but it is prone to degradation upon exposure to light and temperature. And using glass materials is recommended for handling mycolactone. So the work plan we developed at the beginning of the project is as follows, but there were two main challenges. The first one was the need for monoclonal antibodies specific to mycolactone. So to address this challenge, our partner, the Swiss TPH, developed monoclonal antibodies, and these were used to develop a competition ELISA for detection and quantification of mycolactone in a range detected in clinical samples. From there, the best performing antibodies were moved into an RDT prototype. The second challenge was the need to extract mycolactone from a swab sample before applying that to the RDT. The test was configured as a competitive assay, meaning that the test bond disappears in the presence of mycolactone. And several laboratory experimental assays were conducted using synthetic mycolactone to test the limits of detection of the assay and the operational conditions, temperature stability, and many different factors. We then proceeded to conduct feasibility studies in the middle of COVID-19 in Côte d'Ivoire and Cameroon to assess the sensitivity and specificity of fresh samples. The collected samples were analyzed by PCR in the country, PCR and ELISA at Swiss TPH, Switzerland, and the RDT at ELISA. Specificity to M. ulcerans was assessed also in Japan on bacterial samples cultured from non-BU ulcers. Based on our project plan, the next step would be to optimize the tests, do any troubleshooting assays, and design log, followed by which prospective evaluations would be undertaken to assess the clinical performance of the tests, but we are not quite there yet. Through this process, we've also collected a large number of samples, clinical samples. DNA has been extracted from these and is available for the development of other tests. So to address the challenge of concentrating mycolactone, before applying to the RDT, our partner, DDTD in the US, introduced magnetic gold nanoparticles. These are novel nanoparticles which contain a magnetite core, providing magnetic concentration capabilities. It has a silica gel middle layer, which ensures easy resuspension in an aqueous medium, and smooth flow across the test strip. And then it also has an outside shell of gold, which absorbs light extremely efficiently. The gold nanoshell has unusual optical properties, providing very dark blue color, making it easily detectable to the naked eye than the normal nanoparticles using that lateral flow assays. The RDT in the lab met most of the TPP criteria and showed very promising results. So how does it work? The operator receives 2 vials, one loaded with extraction buffer, lyophilized, the other one loaded with extraction buffer, the other with lyophilized magnetic nanoparticles conjugated with our antibodies. Following the collection of the swab samples, the operator dips the swab in the extraction buffer, transfers the mixture to the vial containing the nanoparticles. The mixture is incubated for 30 minutes, and the nanoparticles are concentrated on a magnetic rack. The supernatant is then discarded. The particles are resuspended in chase buffer and added to the lateral flow assay, after which it is read after 30 minutes. And the total time of the assay is roughly 1.5 hours. In the field, things didn't go as planned. Our feasibility studies showed quite inconsistent results. It should be noted that one of the assumptions we unfortunately made was that we would find similar levels of microlactone in all swab samples from the same patient, just like an analyte in blood samples. Thus, multiple swab samples were taken and used for the different assays. But we quickly observed that there was poor concordance between PCR, ELISA, and RDT results. While the test had acceptable specificity and sensitivity, at specificity, at best, the sensitivity was comparable to that of microscopy, and also varied depending on the swab replicates used. So one of the challenges was the concordance between PCR results between the countries and between the Swiss TPH. And here, looking at using the Swiss TPH PCR as a reference, the sensitivity varied between 31 and 39%. But when we use concordant PCR results between the sites and the Swiss TPH, the sensitivity went up to 53%, depending on the swab used. So it became apparent that the sample collection and processing procedures affect the performance of the tests. The number of swabs collected, in this case, we collected 6. The order of the collection, the area of the ulcer where the samples are collected, and the processes, whether we're using frozen or fresh samples, are all factors that can affect the performance of the RDT. Does the sample collection procedures impact the microlactone concentration and the test results? And further, the stability of microlactone could also impact the results of the tests. And ideally, storing samples in ethanol would have been ideal. But in this case, ethanol was not compatible with the assay, so we had that challenge. So what were some of the other challenges observed? The first, as mentioned, was the sensitivity, which is linked to the sample collection and processing. We have observed that microlactone concentration in samples is really not uniform and was lower than expected. Also, there was some loss of microlactone to the swabs. Some loss could be expected due to binding to plastic consumables, and likely also due to storage from the field to the lab. Again, ulcers come in various forms and shapes and sizes. Some are dry, some are wet, some are bloody. Some patients use local remedies with lots of debris, and all of these may affect the stability of and concentration of microlactone. So they should be taken into consideration in developing and validating assays based on microlactone. The reliability of the reference standard was one of the other challenges we have, and because of the concordance between PCR results, it became difficult or impossible to determine which of the samples are truly negative. Again, coming back to the TPP, the fact that there was a need for microlactone concentration makes the test a bit too complicated for use at health centers. And at the moment, the test is better suited for well-trained laboratory technicians. Thus, developing a new test requires the ability to also have enough samples for test development. With the difficulties in getting samples, it took us a long time to collect, sometimes up to 6 months to collect 100 suspected patient samples with active case search activities, and these were all quite very expensive to conduct. So with the development of new molecular tools for BU and point-of-care capability of these tests, such as the LAMP and the biomime assay that's just been presented. And these tests also have better performance and improved turnaround time. The RDT in its current form, we think, has little competitive advantage. However, the tests can be made available as a research use only tests. But perhaps defining the use cases may also be of interest. For instance, can it be used as a screening tool to rule in cases for early treatment, leaving only RDT negative tests to be referred for PCR? And also we need to consider that further work on the RDT will depend on the ability to stabilize mycolactin from degradation. Again, we cannot use ethanol at this moment because we haven't figured out how the compatibility with the RDT. We also need to avoid loss during sampling and processing and the binding to plastic materials. So just to conclude, we developed a BU RDT prototype, currently available as research use only. It has been tested successfully on mycolactin, extracted from cultures and on patient samples. But the sensitivity remains a major challenge that needs to be addressed. And this, we believe, is linked to the characteristics of mycolactin, the sample collection and how they are processed. And all of these hamper future work development on the RDT. There are some key lessons which have been learned in this process on developing RDT based on mycolactin and wound swab samples. And also validating mycolactin as a suitable target for RDT development will be extremely important for any future work on this RDT. So to conclude, I would just like to thank the different partners, institutions that have been involved in the process over the last couple of years. Thank you very much.
Thank you, Zizom. Thank you very much. I mean, what you've just described there is more than probably almost 2 decades of research to get, research and implementation to get to that point. And yeah, I mean, hats off to all involved and just illustrating what a difficult challenge trying to bring these innovative and potentially game-changing diagnostics to where they need to be. So anyway, we should not give up because clearly showing that technology can bridge the challenges. All right, we will change, we will move from Buruli now to yours and hear from Serge Chachuang, who will talk about his experiences across West Africa with laboratory strengthening. Thank you, Serge.
Thank you. Thank you, dear organizer, to give me the opportunity to share experience we have with yours in Cameroon. My presentation is on capacity building in yours reference laboratory in Cameroon, Côte d'Ivoire, and Ghana. Thank you. Many countries around the world are still endemic for yours, particularly in sub-Saharan Africa and South Pacific. There is a big gap on diagnostics of these years in this country, mainly due to the fact that few of these countries have diagnostic platform and lots of data remains on clinical diagnosis. Few molecular diagnosis data that exists came from research project, and there is no, all those samples are analyzed out of this country. As far as is concerned with Africa, Cameroon, Côte d'Ivoire, and Ghana are endemic countries and are part of a project which aims to develop a molecular point of care test to support yours eradication. It is in the logic of this problem that Yes, we undertook this project to establish molecular diagnosis in 3 reference laboratories in Ghana, Côte d'Ivoire, and Cameroon, with Centre Pasteur as in charge of training the 2 other laboratories. It was based, firstly, on the evaluation of the performance of a laboratory in Côte d'Ivoire and Ghana, and then optimize and validate the amplification test, and thirdly, train the personnel in reference lab in this country. Next. The first step was to access the performance of laboratory in Ghana and Côte d'Ivoire through a questionnaire according to the good clinical laboratory practice. For instance, at the level of facility, you have to be sure that the molecular analysis performed there respect the secret of molecular biology. For instance, at least 3 rooms for extraction. For extraction, preparation of mix, and amplification. The second parameter was the availability of personnel, namely and their performance in doing molecular analysis. The third parameter we evaluate was the presence of equipment, namely the real-time machine. We selected a target to perform this capacity building, namely the ribonuclease, which was used to evaluate the quality of sample and absence of inhibitor. The target polymerase 1, which was used to diagnose yaws, and the third one was the variable region 8 to detect Haemophilus ducreyi, which is a bacterium which turned out to be widespread in many skin lesions similar to yours. After this, the verification of this amplification technique, we optimize and validate the amplification test. Thirdly, we train the people in lab reference laboratory in Ghana and Côte d'Ivoire according to the good clinical practice guideline. And also, we implement this activity through observe, supervise, and non-supervised activities. All the work done led us to the following result. Next. In the 2 reference laboratories before the implementation of the project, they were not meeting good clinical laboratory practice. And all were doing molecular analysis. And within the 2 laboratories, only one was actually performing molecular diagnosis of yours with a commercial kit. We noticed from our survey that the personnel was not stable for this activity and were mostly recruited during a research project, which posed a problem of sustainability in diagnosis of yours in endemic country. During this work, we developed many procedures, tested them and validated to implement in this laboratory. The procedure written range from the collection of sample on the field, DNA extraction, diagnosis of yaws, diagnosis of Haemophilus ducreyi, which is a bacterium very prevalent in yaws-like lesion. Also, since now there are many campaign of mass distribution of azithromycin. We have also a technique available to detect resistance for macrolide. After the training, the evaluation, the training of people, of lab staff, was based on reading and explanation of procedure, assay by observation, and then supervision and non-supervision activity. Basically, 10 people were trained during this capacity building, namely 2 technicians from Centre Pasteur, 3 technicians in Noguchi in Ghana, and 5 technicians in Institut Pasteur de Côte d'Ivoire. After this training, the results among the 3 laboratories were comparable, and we are confident that the ability of the laboratory, of the personnel in this laboratory are maintained. And I have to mention that a quality system is also put in place. Next. These are some pictures took during the capacity building in Ghana and Noguchi, and Institut Pasteur de Côte d'Ivoire in Côte d'Ivoire. The main challenge during this capacity building was the shipment of reagent. We have a really big problem in Africa with delivery of product, which can take sometime more than 3 months after ordering. Another challenge we had during the capacity building is that at the time of implementation of the amplification test, molecular platform turns out to be different. As a result, we validate the molecular assay according to the platform so that the results are comparable across the laboratory. Another challenge we face during the capacity building is that it was done during the COVID pandemic with restriction in travel. Next. In conclusion, we can say that actually there is a true reference lab in Africa which is in charge of diagnosing yours with molecular technique in accordance to GCLP guideline to support a national program. And taking into account a previous presentation here on yours, we can say we have now more than a dozen country or territory endemic for yours, and it is important to extend the Lamp for Yours project in all endemic countries so that the approach are harmonized. Next. As take-home message, I will just precise that we have 3 laboratories which analyze by molecular tests yours in Africa, which are Ghana, Côte d'Ivoire, and Cameroon. And quality assurance system in this country have been maintained through evaluation of capacity. And taking the experience from BU LabNet activity, which combine effort among 11 laboratories across Africa, the procedure of this project could be integrated into the BU LabNet for harmonization. We cannot finish this presentation without thanking the AGCP and the Probitas through WHO for fund for optimization and validation tests. I thank you.
Thank you very much, Serge. Another brilliant illustration of the importance of quality molecular diagnostics to be on a firm footing. Thank you. Well, at this point, we can just open for questions on the presentations you've just heard this morning. So we'll invite colleagues to raise their hand, and we have a question here from Dr. Nichols. Thank you.
Muchas gracias, Santiago Nichols.
Thank you very much. It's Santiago Nichols from the Pan American Health Organization. I have the following question. It was very interesting to hear those presentations, and it shows the development of new diagnostic methods for neglected tropical diseases in general and for skin NTDs more specifically, and that's very important. However, I think that we should take some precautions because the development of new diagnostics should not lead us to lose the clinical capacities. What I mean by that is that we need to keep building our clinical diagnostic capacities. We need to, even when there are new diagnostic tools available, give priority to clinical diagnostics, and I'm talking specifically about the case of leprosy. In most cases, they can be diagnosed clinically with lab confirmation. And healthcare workers always want to use diagnostics, even when it is possible, quite simply, to proceed with a clinical diagnostic. It's not that complicated, even for healthcare workers. So that is the message that I wanted to get across. It's the case with leprosy, for example. It's good to develop diagnostics to diagnose infections in cases where there is no clinical manifestation, when there is a subclinical infection. So I think it's important to stress this when developing methods to detect subclinical infections. Thank you.
I might turn to our Spanish-speaking colleagues to respond if a response is required, but...
Muchas gracias.
Thank you very much for this question.
Maybe fine for the audience, or maybe, well, to avoid problems with translation.
I think better to stay in English, yeah. If you can respond in English briefly.
Perfect.
There's interpretation into Spanish, I believe.
Okay, well, I agree with your comment. I think it's quite important do not miss the clinical diagnosis, that's for sure. But I will say that it's, for some diseases, it is very important that we develop confirmatory tests, because otherwise we will not reach several of the targets we have for the control of diseases. An example can be, for example, if you want cutaneous leishmaniasis. Cutaneous leishmaniasis is treated with toxic drugs. In many, many countries, patients are treated based only on the clinical picture. And many people are put into treatment with toxic drugs, and they should not be receiving them. And colleagues from South America can tell you about serious problems that not always are on the papers, because of people are being treated without confirmatory diagnosis, for example. But I agree with you.
Thank you. Thank you. I have my translation sorted now, so next time I'll be better tuned in. I'm going to take a question from up here, and I think it was Santi, if I can see you properly. So please ask your question.
Thank you. It's a question in line with what was suggested. And with Buruli ulcer, we have seen the presentation from Sarah that there is a low positivity in the PCR. And my question is also whether if there has been any clinical cutoff in testing all those samples. And the question is at which point we have the Buruli ulcer clinical score, and at which point that has been implemented and is working, and can we trust on that?
Thank you. I'll have one. I'm just going to pose a question that's been raised here online, and then we'll go back to the floor. So Professor Françoise Portals has a question for Sarah. Why were laboratories outside Africa not included in the quality assurance EQA?
Why laboratory out of Africa have not been included? The first, so at the beginning it was most for African laboratory doing Buruli ulcer, but we have some other laboratories out of Africa, like in Germany, Gisela Lab. We have another one in Spain. The request to be part of the, but we didn't go to the lab and the other lab to offer the external quality assurance. So our aim first was to implement in this lab in Africa and to evaluate the implementation of procedure through this EQA. So some lab asked to also be part of this EQA, and we have 2 European labs. And so I think Bauke also asks for June, next June, so that we can also send them this EQA program.
Thank you, Sarah. I will go to Professor Hay, I think now.
Yeah.
Yeah.
Well, I'm going to ask, this is for Dr. Cruz. I mean, one of the purposes of us meeting today is to identify gaps and find solutions. And you showed a devastating gap right at the beginning of your presentation, which is the funding level for diagnostics. And I just wonder, why is that? Is the research not interesting to funders, and what can we do about it?
That's a very that's a $1 million question. Okay, I would not. Maybe I don't have a clear idea why diagnostics are underfunded compared to other, let's say, interventions for neglected tropical diseases. For example, if you look also at the GFinder report, despite this enthusiasm with the vaccines after COVID-19, a lot of funds or the funding of for developing drugs increased, and we have drugs that may be working for many of these entities. However, this is not the case for diagnostics. Fortunately, there are organizations that are very focused on the field of skin entities, and that they believe improving the research or investing in research for diagnostics is important. And we have, I mean, we know people here in this meeting about this. But for me, one of the important things in order to raise awareness towards diagnostic development is make a good case. So it's okay. We need diagnostics for this disease because if we are not able to confirm the diagnosis, we will not reach this point. And we need to provide figures, and that's our responsibility. Unfortunately, nobody will do it for us. So we need to show the case. We need to show how diagnostics will improve the different aspects of the program, and in the end, the life of the patients of that communities. But we have also to do that exercise. And at the academic level, people doing research in the lab, they are not accustomed to do that. And at the program level, maybe they are just waiting for the diagnostics to come. So someone has to take that thing and move it forward.
I'm just going to use my prerogative as the chair to add, our own experience with Buruli is that it's very hard to get funding for that first discovery step, to make the technological leap, to have the basis of the platform that's going to turn into the field point of care or point of bedside test. And, there was many of us in the room have tried to get these funds, some more successful than others, but it's very hard. It's considered risky. The need is not obvious. It's just tough. Now I'm going to go to Professor Knauf. Please ask your question.
Sascha Knauf, FLI, Germany. I would like to point out one thing that I find very critical and that has not been addressed here. I think these new innovative methods are really great, but one thing what is reality is that our African partners often still have problems to get ordinary primers, oligos, etc., so the consumables. We are in a post-pandemic phase, and we are not making use of the opportunity to scale up and discuss those things. The growing market for consumables is Africa and South America, as far as I can see it. Still, many companies are not having their networks installed so that consumables can be purchased in Africa. And constantly sending consumables from Europe or Northern America to those partners in Africa is destroying the market in Africa and in these low and middle income countries. So we need to have a critical discussion also with the companies, with the private sector, how we can overcome those things. Because we not even have the capacity to create ordinary diagnostics, classical PCRs that are so easy to perform in many settings, and we are not thinking about how to improve this or close this gap. And this is now, in my view, a unique opportunity because after the pandemic with SARS-CoV-2, there is a lot of upscale in laboratory capacity in Africa and South America.
Okay, I'm going to go over here. I think Philippines. I can't see your name, but please ask your question. Yeah.
Thank you. I'm Dr. Belendo Fitas from University of the Philippines, Manila. I'm a dermatologist, and I found yours in my country 5 years ago. My question is regarding the diagnostic tests for yours, which are also looking for H. Ducrey. Is there some sort of clinical correlation with the appearance of the Yost lesions and detection of H. Ducrey among Yost patients? For example, if there are no ulcers in the Yost patient, would the LAMP test be useful enough in terms of detecting H. Ducrey in the same patient? Or is this only useful for patients who have ulcerative types of Yost lesions? Because in my surveys, I didn't find large ulcerations, the small ones. So apparently, the studies I read, you find polymicrobial or H. Ducrey and Yost sometimes in ulcerative Yost lesions. So it's really, was there a clinical correlation when you did the validation tests on the LAMP kit?
Thank you. Serge, Dr. Chachuang, that's a question for you if you'd like to respond.
Thank you for this preoccupation. As far as concerned with the detection of hemophilus Ducrey in your slide region, sometimes it can be present just as commensal and sometimes as infection. Some study in Papua New Guinea have shown infection and also commensalism in those Yost lesions. And what I can also add is that in the environment, we have done some study and we have detected H. Ducrey in animal, form mite, and also flies. The problem now is what maybe the characteristic of strain responsible of infection or just commensalism. This is the point now.
Thank you. I think we have a question straight ahead. Yes, thank you.
Merci, Monsieur le
Thank you, Mr. Chairman. I'm Dr. Abo, I'm the field coordinator for the Lamp for Yours program in Côte d'Ivoire. I'd like to thank all of the speakers for their presentations. But I'd like to talk to Dr. Sarah about the possibility of integrating laboratories within one country. How can you integrate public and private laboratories on neglected tropical diseases? Thank you.
Merci pour votre...
Thank you. Thank you for your question. The laboratory network is open. We focus, first of all, on the laboratories that have the molecular capacities, so the means to carry out these tests, but also laboratories that are specialized in diagnostics. So we don't give priority to research laboratories. We focus mainly on laboratories that support the programs to diagnose diseases. As you will have seen in some countries, 2 or 3 laboratories are part of the program. For the moment, we have 13 laboratories in 9 countries, which means there's more than 1 laboratory in certain countries. In Côte d'Ivoire, it's the Institut Pasteur of Côte d'Ivoire. But if there are other laboratories that are involved in the national programs, because we don't want to integrate a program that doesn't do diagnostics, but the network is open.
I believe there is also an important consequence of our search for new tests is that diagnostics test studies, they often stop in the phase of the lab. So I have the so-called case controls accuracy studies. And if I apply those high sensitivity and specificity tests in the field using the so-called cross-section cohort accuracy study, in which I don't know who has the diagnosis of leprosy or not. I mean, if I have like a 70% or 80% sensitivity of a molecular tests for the diagnosis of leprosy, that's still impressive. So, explaining why I still need the clinical diagnosis and also the test can help me. Of course, for labs, we have discussed also the case definition that is very difficult to compare. So, for epidemiological fields, for example, if I treat all positive PCR, I can break transmission. So, there are many complicated things. And I believe the epidemiological field following the Quadus 2 recommendations must be pursued. Thank you.
Thank you. Sarah, one quick response, and then Kingsley. Okay, Sarah.
Yeah, so I would like briefly to comment on the question on yours and hemophilus decree. I'm a lab person, I'm not a clinical person, but what we saw in the lab is that we are receiving samples from the field, from the program, and those samples are sometimes negative for Buruli ulcer, and mainly for children, they are positive for hemophilus decree. And what we recently realized was to go to the field to get with our oven, and we get samples, and we succeeded to have positive culture for hemophilus decree. So we can think that it's not only commensals, bacteria perhaps also responsible for what we have in the lesion because we have positive culture. So the next step, as he said, is to see if there's a difference when we will characterize those strains.
Kingsley, over to you.
I call myself a dictator, so I take the last 1 minute to talk about, to make some comments. First, about BU LabNet. I think that there have been significant progress over the last few years. But I will also say that we do not want to over-enlarge beyond our capacity. So the focus has been on reference laboratories within countries concerned. There may be the danger to expand too much, but I think the labs within, the reference labs within each country can also support any internal national labs in building their capacities if they want to be involved in supporting national programs within countries. So let's put a limit to how big we can expand. The second question is to GGM. Oh, this is comment, but my question to GGM. After almost 2 decades, as Tim said, trying to develop BU rapid test, I think the outcome has not been what we were expecting. As I've mentioned to you, and I'm mentioning to all the Buruli community here, think outside the box. Because if we want to detect the mycolactin, which is very, very unstable outside the human, outside the lesions, we may have to look at other options of detecting mycolactin. A test does not necessarily have to be the standard test. It could be also a device. We have seen this, what we use for diabetes. It's a device, but it can measure your glucose level. So we need something that can measure and quantify mycolactin in lesions, and I will encourage all to think outside the box. Thank you.
I'm going to draw the session to a close at this point, and could we just join me in thanking all the presenters for this session? Now, before we just launch into the next session, it is time to do our obligatory exercises. So could you please stand up? I've been told we have to do a possum stretch, but I don't want to do possum stretching. We do free, whatever you want to do.
Lead the way.
Oh, no, you cannot post this. No, please don't.
Go on, show us.
No, there's no possum stretching. It's
all right,
just...
come on.
Oh.
Possum stretch.
What is a possum stretch?
I don't know. You're the possum expert. Maybe you needed to go like this. The possum poo.
Yeah, dodging the food. Yeah.
Oh, sorry. That's okay.
Okay, I think. Okay. All right, I welcome you all back to sit down from your stretchers. Thank you, everyone. It's a great pleasure to welcome you back after that invigorating stretch. We'll continue the theme of diagnostics and laboratory capacity strengthening in neglected tropical skin diseases. And to kick off this next session is Dr. Sascha Knauf. Sorry, I just demoted you, Professor Sascha Knauf. My apologies. Could you please take the floor? Thank you.
Okay, thank you very much. Thanks for having me here. Let's see if it works. I will talk about external quality assurance in the fight against neglected tropical diseases with a special focus on the Lamp for Yours project. I would like to acknowledge all the co-authors and start with the problem statement. As you know, there are different levels of healthcare in low and middle income settings. It starts, of course, with the national reference laboratories that are generally well equipped, and then we go down the line: provincial, district, local healthcare centers, dispensaries, and communities. any of these different levels have their special needs and requirements, and in many ways, everything that is under the National Reference Laboratory is not well equipped. We have almost no quality assurance of those tests that are performed on the district level, but this is the front line. I mean, you really want to be sure that what is diagnosed there is true. So we need to have some more quality assurance even below the National Reference Laboratory level. We talk about neglected tropical diseases. Per definition, these are found in the tropics, and this means we have limited resource settings and low payment clientele. So costs are also an issue. And with the LAMP assay that we are currently validating, we think we can serve the needs for those levels under the reference laboratory. The goal is here to establish an EQA program that covers all levels of healthcare in a low-income setting. And high quality, as you know, of laboratory work is the backbone of any disease control, elimination, or eradication program. Without quality, you will not reach your goal. In the LAMP for Yours project, of course, we do have the sampling, and then you have to extract the DNA from those samples. Then a LAMP assay is performed on a district level, and a qPCR is performed on the reference laboratory level. And then we have the data management. And these are critical control points. You can monitor quality in all of these different steps, and it will guide you to improve your system. In the LAMP for Yours project, we do on-site monitoring. I think Sash has outlined it very nicely already. We have organized proficiency testing rounds, and we do retesting of subsets of samples. In this case, 20% of the positive samples and 5% of the negative ones. Now, thinking about how we can set up a proficiency testing item and how do we design it. We decided to use plasmids. In this case, we use a backbone, which is PMA, a plasmid that codes for ampicillin resistance, and we can insert a gene of interest. In this case, it's Treponema pallidum, POL-A, and or Haemophilus ducreyi 16S rRNA gene, parts of it. The pros and cons of this method. The pro is you can distinguish laboratory contamination from wild-type infections or wild-type organisms. Because we don't use whole organism DNA, it is easy to use M13 primers, and you will find out whether it's a plasmid that contaminated your sample or not. Plasmids are super stable, as you will see in a minute. You can transform E. coli and produce as much as you want in terms of the plasmid, so you can produce DNA for the next hundreds of years to run EQA programs. The risk with plasmids is, of course, easy laboratory contamination because they are very stable and small DNA molecules, so you have to be a little bit aware of contamination risk. What we did is we designed an EQA proficiency testing item panel, which is essentially containing 7 different swabs spiked with human HEC293 cells to simulate the background of the samples, and that is used to test for extraction success. And then we have also the plasmids spiked onto these swabs in different constellations: high copy numbers, low copy numbers, no copies. These tests are sent out to the laboratories blinded. They are tested in triplicates, and they are sent under room temperature.
Just, Sasha, just my apologies. We've just got one technical issue. It appears that we're not projecting online. Thank you. Okay. So maybe just if you can consider that in your presentation, and yeah.
No worries.
Thank you. Yeah.
But should I continue?
What will we do? Will we wait? I'll take advice. Okay, we're going to wait a minute just so we can get the slides up for the online audience. Apologies to those online. We'll fix this as soon as we can. I will open the floor then for questions. I think Professor Phillips may have had a question from the previous session, and if you'd still like to pose that, then please.
No, actually it wasn't a question, it was a comment. I wanted to contribute to the discussion on the lab diagnostics from Israel Cruz, but I think we sorted it out here. I wanted to talk about the need for advocacy because a lot of times we don't think about the lab when we are putting in our grant applications and everything is on the implementation aspect, not forgetting that lab forms the backbone to all this. So I just wanted to put that point in that we need to think about that.
Yeah, no, it's a key reminder. If we don't have good lab diagnostics, we're on very unstable ground. Okay, are there any other comments or questions from the previous session that people would like to pose while we wait for the online slides to be displayed? Are there any donors here that would like to comment on their disposition towards funding that gap that Professor Hay just underscored? I would be interested to hear your take on this space in the neglected tropical disease ecology. It's one that's very difficult to address, but donors play a potential role here to help bridge this bottleneck. I think we've got Dr. Marks with a comment or question.
Yeah, sadly, I'm not rich enough to be a donor, but I do share Isra's point. I think, you know, everyone will say that the first decade of progress against NTDs was a decade of just doing, and donors were very keen on, I have given out 100,000 tablets, and not necessarily very keen on measuring whether or not that achieved anything. And I think the new roadmap has put measuring progress with, you know, clear targets central, as Isra has said. The DTAG is quite involved in engaging with donors and trying to get donors to become more interested in this space, particularly around effectively protecting their investment that they have already made. You will lose the gains that you have made against onchocerciasis if we do not X, Y, Z. And this is going to be a key point raised at the project partner meeting that's being organized by the Department of NTDs in June to try and bring donors up to where programs and up to where WHO would like them to be.
Yeah, thanks very much. A response, thank you.
Yeah, can I'm not a donor.
Recording stopped.
But I'm a trustee of an organization that does fund things.
Recording in progress.
And one of the messages I hear from trustees who are experienced in raising money is exactly the point that you made, that the funding's available once you've got the magic bullet that's almost ready to go, but those years of research in developing that magic bullet are not so much interested in. And it's bridging that gap, I think, that's key.
Perhaps before we just reload, because I think we're back online now, and this point has been made, but I will underscore it. COVID has presented an opportunity in this space. The innovation in diagnostics has been outstanding and amazing. And so, yeah, there is an opportunity to bridge that gap with the technology leaps that have been made. Anyway, Professor Knauf, back to you, and apologies for the disruption.
Okay, I start where I stopped, right?
Yes,
okay,
yes.
So back to the panel, the design that we made. And these samples were then sent out at environmental temperature, dry, to the different laboratories. Next slide. I see already, okay. Yeah, here you can see it again illustrated. We spike swap samples with plasmid and HEC cells and send them out to the reference laboratories. Formerly, we thought we'd send it also out to the district level laboratory, but we now let the reference laboratories do the job. I can't see the slides online, so I'm not sure if there's still the problem.
I haven't been alerted. Okay, I have confirmation that they're available. Yeah, thanks.
Okay, then it's sent out to the laboratories, and they have then, once they receive these samples, they have some time to work on these samples and report back the results. Next slide. What you can see here is, first of all, an in-house qPCR using these PT items. The panel, you can see below, Treponema pallidum on the left hand and then Haemophilus ducrei on the right hand. What you can see here is that from the 10 to the 9 copy numbers of the plasmid that are spiked on swab 1, we end up with 10 to the 7 copy numbers in the qPCR. So we know we lose about 2 log scales, 2 to 3 log scales during the extraction. And you can see that this is the case for all the different concentrations for Treponema pallidum and Haemophilus ducrei. Next slide. Now, of course, you want to know how stable is the system. And for that reason, we applied different temperatures. We exposed these swabs to 37 degrees or 56 degrees. We performed different storage conditions in terms of moisture, dry, wet, or in a moisture chamber, and stored these swabs over 180 minutes, 30 days, and 90 days, and then performed a qPCR on it. Next slide. And what you can see is that the plasmids are super stable. Even under the worst conditions, 37 degrees over 3 months in a wet environment, you still have 10 to the 4 copy numbers for Treponema pallidum and a little bit lower copy numbers for Haemophilus ducrei. As long as you keep the swab dry, you can store it for months and you still have a really good performance. This is a case for the Treponema pallidum plasmid containing Treponema pallidum target containing plasmid as well as for Haemophilus ducrei. Next slide. What you can see here is work in progress. That is the result of the first test round that we performed. We used the gold standard qPCR. On the right-hand upper side, you see the internal control. That is the RNase P gene, a housekeeping gene as an internal control. It shows you that extraction happened and that you have DNA in your extraction. Blue is FLI, in-house, and then A and B are participating reference laboratories in Africa. So they all managed to have a positive result, so that's pretty good. And for Treponema pallidum, on the left lower side and Haemophilus ducrei on the right lower side, you can see that all the laboratories also had equal results. So blue again is FLI, and then the 2 participating laboratories in Africa in the other colors. There is no significant difference. These swabs that were sent out performed as expected. We have really good results that show that this is a pretty powerful tool to test for quality assurance. Next slide. Of course, we are also validating the LAMP. The LAMP assay is, of course, a little bit more tricky compared to the qPCR. And you can see that even here, the overall performance is very well. This is, again, the test panel with 7 swabs. Combination of high copy, it starts with high copy numbers for both Treponema pallidum and Haemophilus ducrei on one swab, then high copy numbers Treponema pallidum and low copy numbers ducrei on one swab, etc., etc. The only problem that we see currently is that here we have false negative results when we have high copy numbers for Treponema pallidum and low copy numbers for ducrei. That's a technical issue that we're trying to find out, but overall the test performances are looking pretty good and stable. Next slide. So the conclusion here is that for the LAMP, for yours EQA, it's of course needed to have a critical evaluation once all the proficiency testing rounds are done. We are currently in the process of performing the second round, expecting to get the results in the next days, and then the third round will start also soon. Currently the results are really promising. The LAMP performance is poorer compared to the qPCR, but that's nothing that worries us. That was somehow also expected. And generally, in terms of EQA, I think it can be clearly said that these quality assurance programs are really a need for NTD programs, also at levels under the reference laboratory. We need more EQA programs on the district level because these are the frontline healthcare workers that have to confirm cases. The LAMP for Yours project could be also used as a blueprint for other programs. And I think I have to underline it again, and let me be very clear here, we need cross-sectoral EQA programs. We will never ever manage to control, eradicate, or eliminate diseases if we do not work across the different sectors applying a One Health approach. We need to combine multiple programs to save resources. That was also something that has been said, and there's hopefully a good opportunity also to work with the BU LabNet to also get this LAMP EQA further upscaled. Next slide. The take-home message is, this is not rocket science. We are not aiming to have an accreditation according to ISO norms here, but we are aiming to improve the quality at the district level and even in reference laboratories in low and middle income countries. And EQA is really central to the quality of the data that are generated, and to really be sure that that countries are disease-free or not. Next slide. I would like to thank, of course, the funding institution, the European Union, EDCDP program, and all the participating institutions and countries. I think it's a great teamwork, and hopefully we will have some impact on future programs. Next slide. And with this, I would like to thank you for your attention. One Health for yours and for all.
Thank you for that presentation. We'll move directly to our next presenter. It's Dr. Wendy van der Sun, who will switch gears now for us and move to diagnostics for mycetoma. Thank you.
Thank you for the organization to let me present the work on mycetoma. Can I have the slides, please? So my name is Wendy van Sande and I'm from Erasmus MC in Rotterdam. And today I will talk about the molecular diagnostics for mycetoma. So after the presentation yesterday of Professor Verhaal, I don't have to say too much about what mycetoma is. But key here is that mycetoma can be caused by 70 different causative agents, either fungi or bacteria. And if you look worldwide, the fungus Margella mycetomatis is by far the most common causative agent, followed by the bacteria Nocardia brasiliensis. But this etiology differs per region. So in Africa you find more Margella mycetomatis, while in Latin America Nocardia brasiliensis is more prevalent. For the diagnosis, most laboratories use clinical diagnosis first, and then combine it with surgical biopsy to perform histology and culture. And this was a survey done by Professor Hay. However, with histology, you cannot differentiate the causative agent to the species level, because most of the grains look very similar in histology. With culture, especially with the fungi, you lack discriminated features, because most of these fungi don't sporulate, so it's very difficult to say which causative agent it is. Furthermore, it's very lengthy. So if you look at this study performed by Emanuel Siddig, you see that it took a median of 8.5 days to come to a diagnosis using histology, and 21 days when you use culture. So the misidentifications are also a problem here. So the objective was to develop a molecular identification tool for the most common causative agent to provide a more rapid and accurate identification. And first we focused on the main causative agent, the fungus Margella mycetomatis. So one of the hallmarks of mycetoma is that the causative agent organizes itself in a grain, which is like in the case of Margella mycetomatis, a sort of pepper ball, where the fungus is embedded in a cement material, and it's very harsh material, so you need force to disrupt this grain. So these grains were classically obtained by a deep-seated biopsy, which is of course an invasive procedure. So we wondered if we could also use a less invasive procedure, ultrasound fine needle aspiration. So we isolated the grains with these two methods, isolated DNA and performed a PCR. And as you can see from these 34 patients included in this small study, 31 were positive if you take your grain with a deep-seated biopsy, 3 were negative. If we obtained the grains by fine needle aspiration, we only missed 1 patient. So this proved that a less invasive method could also be used to obtain grains for molecular diagnostics. The second requirement is to obtain DNA. And for strains, this worked very well. So we can use very basic methodology, bead beating with glass beads, followed by CTAP, chloroform, on isoamyl alcohol. This worked very well for most fungal isolates, but it didn't work for the grains. Then we used the Zymo kit, which we use in our lab. It also worked very well on the strains, but again, no DNA was obtained from the grains. Only when we replaced the beads we used for bead beatings with metal beads, actually the things you use in a bike, then we had enough force to disrupt these grains and could isolate DNA. We could isolate DNA with a kit from QIAGEN and with the Zymo kit. But in our experience, the Zymo kit performed better because from all the grains we tried, we got amplifiable DNA, while with QIAGEN, only half of the grains we could amplify. So then, of course, the third requirement is your amplification target. And for fungi, the most common used target is the internally transcribed spacer region. It's a barcoding gene. And if you compare all the internally transcribed spacer regions of fungi, and especially to the close relatives of Margella mystomatis, there are a few unique regions which you can use to design your PCR primers. And this is work done already in 1999. And we were able to develop 2 primer pairs, primer pair A and primer pair B, which were specific for Margella mystomatis in silico. And when we tested this in vitro, we also saw with this large strain collection that only Margella mystomatis amplified with these primers, and the other eumystoma causative agents did not. It didn't only work on an isolate from a reference collection, it also did work on the clinical isolates. However, in 1999, not all causative agents were identified, and it was on a later time point that we discovered that Margella mystomatis actually has very closely related sibling species. And more worrying, one of those species is resistant towards itraconazole. So we tested all primer pairs, and it appeared that primer pair B was genus-specific, but not species-specific, so we could not use this one to identify to the species level. And primer pair A, you see that Margella mystomatis gave 2 bands on the right side, so between 400 and 600 base pair, but you see also a band and a higher size, that was actually Margella pseudomystomatis, which seemed to cross-react with this primer pair. So therefore, we took a comparative genomics approach, and we made use of the genome we published to find a region inside the genome which was unique for Margella mystomatis, and we designed a 3rd PCR. But looking at these PCRs and validating them only against laboratory isolates is of course not a very trustworthy procedure. So together with the Mycetoma Research Center, we again did a large study in which 202 patients were included, which were 180 males and 41 females. And that's roughly the same male to female ratio you see in the normal patient population. So we sequenced, we used ITS sequence as the golden reference because we knew that culture would not reliably discriminate all the causative agents. And of these 222 patients, 194 were infected with Margella mystomatis, 3 with Falciformis spora senegalensis, and then we also see the Margella sibling species. And we validated both PCRs. So if we look at the first PCR, where we see this band cross-reacting with Margella pseudomystomatis, Out of the 194 patients with Margella mystomatis, 192 were positive, the others were negative. And also the single isolate of Margella pseudomystomatis did react, but the band was of a different size as what we see with the reference collection. The time to identification was only 3.8 hours, and we had a high sensitivity and specificity in this cohort of patients. When we looked at the second PCR, where there was no cross-reactivity with Margella pseudomystomatis, it performed equally well. So the same 192 patients were positive for this PCR as well. There was no cross-reactivity with Margella pseudomystomatis, and this PCR was even more rapid, so the time to identification was 2.8 hours. So if we look back to the time it took for histopathology and culture, this reduced the time to identification with at least a week, and if you compare it with culture, with 3 weeks. Of course, these were based on a classical PCR, and there are new ways to amplify DNA. So we also developed real-time PCRs, as you can see here. Some were developed based on the same target, so the internally transcribed space region. Others were developed on beta-tubulin and an intergenic region. And they were also very sensitive, but we used the melting curve analysis here to discriminate between the different species. And for those laboratories who don't have access to a PCR machine, we also looked into isothermal amplification techniques. So we used LAMP, where you only need a heating block of 65 degrees, and we developed an RPA, which can actually be performed with a heating block at 39 degrees, but even if you don't have a heating block, you could also perform it in a normal incubator, which is present in most of the laboratories. LAMP only took 2 hours to perform, and it had 100% specificity. RPA was even shorter, and it took 40 minutes, and we could even make it shorter if we use probes. So the main challenges we had were that we need to obtain the grain from the lesion, and this is still an invasive procedure. But without the grain, you cannot obtain the DNA needed for these PCR tests. And although we can currently isolate DNA from the grains, you still need the bead beating and a kit. So this is a labor-intensive procedure and not very field-friendly. And currently, all these tools have been developed for Margella species, but those are not everywhere the most prevalent species. So in some regions, for instance in Western Africa, you would expect more Falciforme Spora senegalensis, and in Latin America, you would expect more Nocardia brasiliensis. So, what we were able to obtain is that we can do this PCR, and we can do this on fine needle aspiration. We can do it directly on grains, so omitting the need to culture first. So this reduced already the time to identification with 6 weeks. They have been clinically evaluated, and there are different formats currently available. But for the different other pathogens, with the project funded by the organization Diagnostics, we now have developed primers for other species, like Falciforme Spora senegalensis, but also for the bacterial-causative agents Streptomyces somaliensis, sudanensis, Actina madura pelletri and maduriae, but also Nocardia brasiliensis. And we are developing these into different formats, multiplex PCR, real-time multiplex PCR, and also RPA, so that every lab setting will be able to use these targets for the amplification and for molecular diagnostics. And of course, this work has been the work for many years. It has not been done only in a week's time. So this has been done mainly by PhD students, including Abdallah Ahmed from the beginning, but also Wilson Lim, Bertrand Nicounye from our lab, and especially Sarah and Emmanuel from the Mycetoma Research Center, who did the clinical evaluation in the lab. And with this, I thank you all for listening.
Thank you, Professor van der Sande. And yeah, what a wonderful introduction to mycetoma diagnostics and the challenges that you face. I've got some questions for you, but I'll hold them to the appropriate time. Thank you. All right, so we'll move to our next presenter. Thank you. Abigail Agbanyo, and she will talk to us about lab support for the control and elimination of skin neglected tropical diseases in Ghana. Thank you.
Thank you very much for the opportunity. I'm presenting on the laboratory support for the control and elimination of skin neglected tropical diseases in Ghana. Next slide, please. The next. Okay, so integration, as we all have been talking about, and WHO has it in its 2030 roadmap, as the best approach in addressing skin NTDs will have its success largely dependent on a strong laboratory base. So in Ghana, there was an integrated program that was implemented in 15 selected districts with KCCR and Noguchi offering laboratory strengthening program that fed into the bigger implementation program. Next, please. So our overall aim was to strengthen laboratory diagnosis for skin NTDs by using an integrated approach. Specifically, we sought to improve the overall quality in sample collection, storage, transport, processing, and results reporting, and also to improve the knowledge and skills of healthcare practitioners that were responsible for handling samples. The map on the left shows the 7 selected districts that KCCR worked in, and these districts were carefully selected to align with the case distribution maps as we see in the Ghana NTD master plan, as we can see on the right for leprosy, Bruley ulcer, and Jaws. Next, please. All right, so what were the approaches used? For uniformity and for quality, SOPs that needed to be used at all stages of the implementation program was harmonized. And with this, there was a meeting with representatives from all the labs that came together. SOPs were collated, they were reviewed, adopted, and a unified document created that had SOPs to be used at all stages of the program. And this included sample collection, sample storage, sample transport, and then results reporting. Also, because training is key to the success of this program, we trained the health staff in the 7 selected districts who were involved in skin NTD activities using the harmonized protocols, and these the training included sample collection, sample storage, sample transport, and also documentation using the WHO clinical and epidemiological data sheet, and also the skin NTD 01 form. This was done because we believe that once there is quality at this stage, there will be quality of samples that come to the lab and improve the overall quality of data that is generated. Also, supervisory and monitoring activities were instituted in these 7 selected districts to check adherence to the protocols. Another role of KCCR was to offer laboratory confirmation for the samples that we received from the district and also provide timely results to the district. And this was done through WhatsApp and emails, the district directors and the focal persons for case management to begin. Data from all these activities were sent to the National Control Program, who were actively involved in all the activities for onward submission to the WHO. These are images from the harmonization meeting that we had. And I must say that this was before the BU LabNet consortium came in. And once the protocols were finalized, they were adopted for laboratory confirmation of BU. This is also pictures from the extensive district trainings that we had in the 7 selected districts. These photos are from the monitoring and supervisory visits that we had in the district, and the photo on the right shows the terrain in which we worked in. Sometimes we had to cross rivers and bushes to offer training and supervisory visits. Some few results from our study. We were successful in harmonizing SOPs that were to be used at all stages of the implementation program. Also, 114 healthcare practitioners that included disease control officers, district directors of health services, lab technicians, nurses, and community-based surveillance volunteers were trained in the 7 selected districts. Also, we were successful in sending results back to the district in less than a week of receipt of samples in the lab. In total, we had samples coming in for 1,051 patients who were suspected of skin lesions, and out of this, 976 were suspected brucellosa cases, and then 75 were DPP yaws positive cases. Concentrating on BU, out of the 976, we had 164 coming positive after PCR. I'll talk about this more in the next slide. Going back to yours, the 75 samples were subjected to a multiplex PCR that could simultaneously detect Treponema pallidum and Haemophilus ducreyi, and these are the results that we had. We had about 9% of them being mono-infected with Treponema pallidum, 37% being mono-infected with Haemophilus ducreyi, and 9% co-infected with Treponema pallidum and Haemophilus ducreyi. 44% of these samples were negative for either of the organisms, and this from literature could be due to the latent stage of the disease. Going back to BU, there was a positivity rate of about 17%, which was quite low. But then we realized that 2 districts, Asante Akim North and Upper Dentra East, had a relatively high positivity rate, over 30% positivity rate. And this could be attributed to earlier years of consistent training and education in those districts. Also, ulcers were the most clinical forms that were recorded. However, Category 1 and Category 2 lesions accounted for about 73% of all the cases that were confirmed, and this we saw to be good for the control of Bruley ulcer because these cases, when treated early, are known to have better outcomes. Some key observations from our study, as I said earlier on, 2 districts had a relatively higher positivity rate, and also, although our positivity rate was quite low, we realized that those who used the BU clinical and epidemiological data sheet, or the scoring sheet, who had likely BU or very likely BU conclusions, had a high concordance with PCR, about 99% concordance with PCR, and we think that was good. Also, Category 1 and 2 lesions accounted for the most lesions that were confirmed. Adding to the knowledge, following PCR, realized that DPP positive cases could either be due to a mono-infection with Treponema pallidum or Haemophilus ducreyi, or a co-infection with both. The main challenges that we faced was the high attrition rate of the trained health staff, which also led to a challenge in the data collection and completing of request forms. And with this, continuous trainings during the monitoring visit was done to fill up for these gaps. Also, there was a challenge with the follow-up of patients in hard-to-reach areas. Next, please. In summary, we believe that implementing an integrated skin NTD program is feasible and should be encouraged because it has the likelihood to improve the care of patients living with such conditions. However, a strong laboratory network is needed for the success of this implementation program. Some key take-home messages are that there should be a strong laboratory support for accurate surveillance and case management in these programs. Also, there should be quality at all levels of the implementation program to assure accurate laboratory confirmation. Training and capacity building activities are also key in the success of this program. Monitoring and supervisory visits, we believe, should be implemented, and a good communication network and timeliness in results reporting is key. We are thankful to the NSVAD Foundation for their support, to the Ghana Health Service and then program managers of the Borreliosa, Yaws and Leprosy Control Program in Ghana, to the directors and staff of the 7 selected districts that we worked in, and to the Skin NTD group at KCCR. We are grateful. Thank you.
Thank you very much. Yeah, what a great demonstration of the importance of quality lab diagnostics and active case finding. We'll move to our last presenter, which is Dr. Andy Vonda, who will talk to us about innovations in diagnostics, and one in particular, I think. Thank you.
So welcome everyone. The next few minutes I'm going to show you the benefits that that SwiftX technology can bring into molecular testing of skin NTDs. But before I start that, a few words about the company itself. Expedite Diagnostics, it's a rather small player, not as known as the big players in the industry. So we are still a startup company founded in end of 2020, and we are privately owned, have no venture capital behind us, which makes us more free in terms of operations. Our operations are ISO 9001 certified, and we are also a registered IVD manufacturer within Europe under the new IVD regulation. So our core competency is the development and manufacturing of DNA and RNA extraction kits and solutions. We have meanwhile sold almost 250,000 extractions worldwide, and we also do contract development for other IVD companies. And our main focus is on parasitology and bacteriology right now, and we are still small, but we are establishing a network in low and middle income countries, doing for example, setting up distributors and collaborators in Latin America and Africa. So the objective of our endeavors is to provide researchers and also diagnostic laboratories with tools that basically comply with the assured criteria. Our extraction kits are very fair priced, so they can be sold for low cost or purchased for low cost. And they enable a highly specific and sensitive molecular diagnostics, because you know every diagnostic assay is only as good as the extraction upfront to the assay. The methodology is very easy to train, so it supports use in not so highly equipped laboratories and personnel. The procedure itself is very time efficient, and also the purification mechanism is very rapid. Good thing is that you need really minimal equipment to perform the extractions. It is all completely independent of cold chain storage. And as I try to point out, we are committed to supply also our solutions to low and middle income countries. On top of that, it's maybe worthwhile to know that all these reagents are very eco-friendly because they don't use any hazardous chemicals, and they also allow multiplex detection of various diseases. So first of all, I want to show you briefly how the whole method works. So first step is the cell capture, where we employ magnetic particles to bind to cell surfaces. These particles are then dragged apart, and you can remove the sample specimen, the matrix with all the inhibitors, and the captured cells are then rehydrated or resuspended in a lysis buffer, usually heat extracted. And the last step is the reverse purification, means the magnetic particles still bound to the cell debris and other biomolecules are again magnetically separated, and what remains is a kind of cleared lysate containing the DNA and RNA. So this capturing and lysis mechanism works very well for basically all sorts of pathogens such as parasites, helmet eggs, bacteria, and also some viruses, but also for the host tissue. And the lysates can be very well applied to analysis methods such as real-time PCR, but also isothermal amplifications, and also for next-gen sequencing. So since the type of specimens can be very variable, we have come up with a system of a set of protocols which are dedicated to a certain group of samples. Protocol 1 is dedicated for use with solid specimens such as tissue biopsies or concentrated cells or swapped samples, where these materials basically indulge directly in the lysis buffer for extraction and reverse purification. It's a very rapid process. And Protocol 2 is dealing with liquid specimens such as fine needle aspirates, saliva, urine, and so on, where you have the cell capture module up front to the lysis module. And Protocol 3 is essentially identical to Protocol 2, but we have there an additional wash step to remove more inhibitory substances, and that's why this protocol is recommended for whole blood or stool samples. All these workflows can be either performed manually in a laboratory environment or even in a field, or if you have higher demand of throughput, then it can also be easily automated on different liquid handling machines. So talking about this field extraction, we have also a customizable mobile laboratory developed that goes back to the work of Abdel Wachet and Meitman, who developed such a mobile suitcase for the Ebola outbreak in 2015. So we have optimized that in terms of increasing usability and customization possibilities. So the whole lab is basically enclosed in a very rugged plastic housing, which is, for example, also used by the US military. It's IATA conform, so you can take it to any travels and, of course, into the field. It fits all the instruments and consumables that you will need for your molecular workflow. And it is also equipped with solar panels and lithium-ion battery, which both can be also customized in terms of capacity and size. And if you look into the suitcase lab, we have an LED light for better lighting of the work table. There is a magnetic inner lid surface, which means you can freely arrange all your accessories, such as the pipette holders, timer, gloves, wipes, and so on the back side of the lab to fit your needs. The lab itself is equipped with a spinner, a vortex, a heating block, pipettes, and also a magnetic rack, so everything that you need for performing a full extraction workflow in the field. There is also a section for storage for storage of samples or reagents, and space for a detection instrument that can, for example, be a real-time PCR cycler, a small one like the one from BMS, the mix cycler, or it can also be a detection instrument for LAMP or for RPA detection. And the whole workflow basically takes place on a stainless steel work table, which makes decontamination after you have done the work very easy. So now some application data. So the method were applied in recent years for testing for cutaneous and visceral lesion analysis. There are several peer-reviewed papers, also posters and a validation report available. And the technology will be used in a Bill and Melinda Gates funded project in India for field validation of a POC test for BKDL and leprosy diagnosis. This is led by the University of Leipzig. In terms of mycobacterial diseases such as Borrelia ulcer or leprosy, we have engaged in collaboration with a group of Estelle Marion and Gisela Brezel. Here are some data sets from these collaborations. You see a comparison of extraction using SwiftX DNA compared to genolyze, which is another rapid extraction method. You see a very high equivalency in terms of the results, but the big difference is that the extraction workflow is so much easier with SwiftX DNA. And also here is a further validation planned, led by American Leprosy Mission and funded by Hannes Watt Foundation, where SwiftX DNA will be used as one of the extraction methods as an upfront tool or extraction for the multiplex PCR of several skin entities. Application data for fungal diseases, we have conducted a validation study with the German Reference Center for dermatophytes last year that was published on a conference, and that showed very nice also equivalence to the QIAGEN reference extraction method. And here we are going to conduct further validation activities together with the Erasmus Medical Center for mycetoma samples, and we will also internally perform a further development together with the German Reference Center for these dermatophytes and an IVD company located in the north of Germany for multiplex species-specific PCR diagnostics. So in terms of spirochetes, such as the Treponema, we have data showing that the cell capture and the extraction works very well for Borrelia and Leptospira, which are both spirochetes. That's why this really indicates that the extraction method itself is likely very well applicable to Treponema pallidum, which is the causative agent of yours. And beyond that, our reagents and protocols are also involved in another EU Horizon project led by University of Leipzig again, where they perform direct extraction of mosquitoes for the purpose of biosurveillance of emerging diseases within Europe. And they also use nanopore sequencing for deep data collection for that. And that might be an option also for surveillance of lymphatic filariasis and onchocerciasis as well. So I'd like to thank all the collaborators on these skin NTD-related projects, such as the University of Leipzig, the INSERM Institute, the American Leprosy Mission, the University of Munich, and also the Erasmus Medical Center. And last slide here, again, basically summarizing what's the advantages of the SwiftX extraction technology. It's, I think, unique that it includes a cell capture step where you can really enrich your biological targets as part of the extraction procedure. The cell lysis itself is very strong. The reverse purification is very quick and efficient. All the reagents are non-hazardous. So, and the whole workflow is very rapid and also easy to teach. And the big advantage is you can apply this single kit for the extraction of samples towards testing of multiple skin diseases, skin NTDs. And finally, I'd like to also mention that we plan to CE-IVD mark this extraction kit in the course of the year based on Leishmania, schistosomiasis, and Mycobacterium ulcerans, as well as lepra and HPV data that we have gathered so far. Thank you very much.
Yeah, thanks very much, Dr. Vender. Nice demonstration of technology. So we'll open now for questions for any of our presenters in this session. So I invite you to raise your hand, and Sandeep, I'll see your hand up first. Thank you.
This is not a question, but a clarification. In a couple of presentations, you have heard about BioMe multiplex qPCR project for multiple skin entities. We missed acknowledging the partners who are actually funding it. It's American Leprosy Mission's Hannes Watt Foundation and Foundation Rolf Loru. We missed including that in the presentations, both me and Andy. So I think that's a clarification for the floor, and that's an oversight. Thank you.
Okay, an important clarification. Thank you. I might have a question for Andy, and a little bit more detail, please, on perhaps costs. You know, if a laboratory in West Africa wanted to purchase a suitcase with your workflow, how much might it cost? How much might it cost per test? Mm-hmm. And maybe some details about the amount of training required for someone to be competent in using the entire workflow.
Well, so we have list prices, of course, which are more adapted to the Western markets, but our price structure allows for a very low price point. Of course, we will not get as low as for lateral flow testing. That is probably out of the range, but it's also, of course, a number issue of the numbers of the scale that you can use the reagents for, but in general, it's very competitive compared to other competitors. Yeah. And in terms of training, of course, I mean, what we do as a small company is one of the value propositions that we provide is to have a very close relationship to our customers, and we provide technical expertise basically always, and also discuss results, initial results, and validation trials, and so on. So that is really an advantage that we have over our other bigger companies, bigger competitors.
Thank you. We have a question online that I'll for Professor van der Sande, and the question is around, well, it's from, excuse me, while I just focus, Sarosh Jamil, who's asking, are there special requirements for transporting FNA specimens for Mycetoma Diagnostics?
Well, the assay we did was in the Mycetoma Research Center, and that was done there on the spot. So maybe Professor Verhaal could address that question, what if you wanted to transport this?
Actually, we took the specimen from the clinic to the lab, which is about 5 minutes walk in between, and we put it in a dry slide, and that is it. It's very simple and very quick.
Okay, thank you. Any other questions from the audience? Comments? Kingsley.
Well, if I understood the question well, team, you meant if the samples are not taken directly on site and they have to be taken off-site and transported to the lab, how would the samples be transported? Well, that was my layman's understanding, but maybe if you want to clarify.
I think that's right. If you don't have the close proximity between patient and laboratory, how should the FNA specimen be stored for stable?
As I mentioned, either put it in the syringe we take the aspirate in the syringe, and then we transfer to the lab, or in a dry slide, and then we spread it in the dry slide, and then we take it to the lab after that.
If I can comment on that, one of the downsides of the grain is that it's very difficult to disrupt. But for transportation, that's also a pro because it's relatively stable. We actually have isolates which we stored just a lesion in a -80, where we didn't do any preservatives. And if you take it out and you open it, the grains come out and you can still isolate DNA. So the DNA inside the grain is relatively stable, and the grain itself is very difficult to disrupt. But of course, more tests are needed to see how long we can store these and under which conditions the DNA is stable enough. And these are experiments we still need to do.
Now, I think we have a question in the audience from Dallas Smith.
Hi, everyone. My name is Dallas Smith, and I'm from the Mycotic Diseases branch at the CDC. My question is actually for Andy. One of the things we're pretty concerned about now globally is the emergence of drug-resistant dermatophytes. And I was kind of curious if your diagnostic tools would be able to address that, or just species in general.
Yeah, I mean, the extraction part, that is our core technology, is always independent of what you do in the end. So yeah, if you extract the DNA, you can do, as I said, nanopore sequencing or multiplex testing for resistances. So that is definitely also supported, just by definition, let's say.
Yes, Professor Hay.
I had a question for Abigail, which is really whether she's got any thoughts on the negative ulcers that you had, because there's been recent publication from Brad Gressadair and Oriel Midger and others suggesting that some of those may be associated with strep pyogenes or some anaerobes such as fusobacteria. I just wondered whether you've taken those negatives any further.
Thank you. I think, yes, we've had a number of negatives, and what you are saying now has been considered, and hopefully in the near future, we would look at what is really causing the number of negatives that we are having for the BU cases.
Yes, Michael Marks, I think.
Maybe I'll just comment on that, seeing as our group's done quite a lot of the work on the Ducret lesions. It's quite difficult to untangle what the cause of the lesions are when they're negative for both treponema pallidum and H. Ducret, because the techniques that we're all using, 16S and shotgun metagenomics, we're getting a sort of soup of organisms. And so we're finding streps and staphs and pseudomonases and some anaerobes, but many of those organisms live on the skin anyway. So really fulfilling Koch's postulates to the extent that they are causatively important in the ulcers has proved quite tricky. We've got some current running work across Ghana, Cote d'Ivoire and Cameroon where we're going to have control swabs, both from a normal bit of skin from the same patient and from someone who doesn't have an ulcer. And that may help us disentangle a little bit what is just on the skin versus what is really causing the ulcer, but we don't really know. In the trials that we've run with Kingsley in Ghana and in Papua New Guinea, those ulcers respond very well to standard treatment. So they presumably are bacterial in origin and do respond to a single dose of azithromycin. So on a sort of day-to-day basis, they can be treated very similarly, although it's obviously academically interesting to understand what's driving them microbiologically.
Now, I have a question for Professor Knauth, and it's about the disparity between LAMP and qPCR, and you're using a synthetic template, your plasmid, your cloned fragments. Is there an issue where you're using a non-authentic template and secondary structures in your DNA are giving you a sort of an artifact in LAMP performance that you wouldn't see if you used the DNA or RNA in its native context?
That's a good question. Actually, what we see in the LAMP, the results that I showed you from this first round, are remarkable in one way because you would expect more false positives, because the LAMP reaction, once it starts, it's difficult to stop and then you get false positives. So you would expect that you would see this more often than having false negatives. From this perspective, I'm also not so much worried about this false negative result here, and we're working on this. Because it looks like generally these results are pretty consistent. And you saw that the false negative result was also in all three laboratories. So we have little variation in the results, which makes me confident that we don't have problems with anything that comes from the plasmid that starts the reaction. But it's clear that LAMP uses more primers than the classical PCR, and it's not so trivial to really design the primers, and maybe in other settings, other diseases where you do the same thing, you have to do some more establishing the method. But for this LAMP, I'm pretty confident that we don't have an interference with the synthetic controls.
Okay, thank you. Are there any more questions from the floor or online? I'll ask my colleagues. Perhaps one more online.
Yep, I'm just sending it to you.
Right. This is a question for our mycetoma colleagues. Are community health workers involved in collecting samples?
So far, the collection of samples was mainly done at the Mycetoma Research Center, by surgeons and technicians, but that would be, of course, the plan for the future. Maybe Prof would like to comment on that as well?
Thank you. And perhaps one more question from me before we finish up to our mycetoma colleagues, in particular Professor van der Sande. Is genomics entering the field of mycetoma research now and giving you more options for molecular targets?
Yeah, so in our Diagnostics project, together with CDC and with the University of Sydney, we include whole genomics to identify more targets, because one of the difficulties we had is that it's 70 different causative agents, and, well, you want to have a specific assay, especially since we see that there's resistance rising in the actinomycetes. Some of the fungal causative agents don't respond well to itraconazole, at least in vitro. So we really want to be able to differentiate those. So we use a whole genomic approach to find novel targets which are more discriminative. Because as well as the previous comment mentioned before, in those mycetoma lesions, you also have other bacteria present. And you don't want a PCR which will also pick up those. So that was one of the downsides we had in the past when we did molecular diagnostics directly on grains using barcoding sequencing. We simply picked up also the Staphylococcus present. So we needed specific targets, and we stumbled upon a few using the whole genomic approach, which look very promising and which are very discriminative, for instance, between Streptomyces and Actinomyces.
Thank you very much. I mean, I think it's perhaps a good point to end on, that technology can help us, will help us, is helping us, but we have some hard work to do to use all that potential. Well, could you please join me in thanking all our presenters in this session and the one previous? We have 10 minutes. I think it's okay. I'll defer to the Chief and ask him if he wants to say anything before we're dismissed for lunch.
I think we can have early lunch today. I just have a few announcements. So at 12:30, there is a private meeting, only by invitation, on discussions around Taliseberg with the TB Alliance. After the close of the afternoon sessions, there are different side meetings. One is with the ILDS. This will be in room D46025. All the participants have been notified. This is also by invitation. There's the UK Prosper Network meeting. That will be in room W2, also by invitation. And then the Global Leprosy Program and the WHO Regional Focal Points, they have a meeting in room D42022. All have been notified. I think it's been very impressive morning, interesting presentations on diagnostics. I always say that surveillance without lab backup is meaningless. What are you counting? What are you reporting? So I also want to encourage partners sitting here that if you support projects without strong lab components, we will not allow the data to be presented in WHO meetings. We are under very strict requirement to ensure data quality in that WHO report. So to my country programs here and to partners, researchers, and WHO colleagues, let's make sure that data that we publish on our websites are credible, and therefore the lab aspects should be strengthened in all countries. I'm glad to see the BU LabNet progress. But I hope that in other regions, other countries, there will be efforts also to improve lab capacity for NTDs. All right. Let us meet before 2 o'clock, please. The next session on treatment is also going to be very exciting, and we should all be here in time. Have a nice lunch.